Yeah, nice. Keep the wire in that position and walk it out. Store fluoro, please. Okay, balloon, please. Fix the wire. Yes, sir, that's fine. Okay. So wait. You are ready, huh? Are you ready? Yeah, okay. Sini, sir, pacing on. Wait. Pacing on. 180. Let the pressure drop. Let us see the pressure drop to 50. Wait. Now go up. Hold the balloon, sir. It will go down. Yeah. Down. Balloon down. Pacing down. Okay, that's fine. Walk it out. Yeah, walk it out. Yeah. Good. Walk it out. Because LV is so powerful. LV is so powerful. So you see the pressure consistently dropping below 50. So if the pressure is not dropping, then you increase the pacing rate from 180 to 200. Yeah, fix the wires. Yeah. Give some dry swabs to sir here. Okay. Bring the valve. Okay, I'll fix this. You get the valve. Fluoro, make sure the wire is in. Yeah, perfect. Yeah, nice. Lovely. Keep it nice and straight. Nice and straight. Wire out, huh? Wire out. Fix the wire. Fix the wire. So first the loader in, sir. Push the loader all the way in. Yeah, all the way in. Yeah. Now push the valve. Fluoro, sir. Fluoro. Yeah, fix the wire there. Little bit, sir. Enough, sir. Now just bring the loader back. Okay, now it will be easy to hold. With the loader, it will be difficult. So it's okay, ma. If it's difficult, we'll see. Yeah. Sir is doing well. Fix the wire. The wire tension is. Yeah. Yes, sir. You're doing well. 1 second, sir. 1 second. So always fix it like this. Okay. Yes. Let it come there. Stop there, sir. Stop there. Go a little bit. LIO, please. Fluoro, sir. Fluoro. Keep going. Keep going. I want to see the aorta open up. Stop. Now stop. Because the aorta is opened up. Center it and show everything. Yeah, perfect. Lock the table there. Locked, da. Okay. So as you are going, I will give you a flexion, sir. Merrill is completely down. Let it come back, sir. Fluoro. Okay, stop. Fluoro, sir. Fluoro. Yeah, take it. Okay, you fix the wire. Take it, sir. You take it, sir. Yeah, it's 50%. Go in. I'll give you some more. That's 70%, 80%. Cross it. Yeah, stop. Yeah, I'm releasing. Fluoro's there. Store fluoro. I'm just releasing the flexion, what we had, so that it will self-center. Yes, sir, a little bit. That's okay, sir. We'll check it because we want the pigtail to be on the second dense band. It looks good. We can always adjust it. You hold it. Okay, give one picture, please.
Ready for injection?
So our pigtail has come up. So the best thing is to, no, it is entangled. Fluorescent. Let's go in the outer curve. Yeah, that's perfect. It's fine, sir. It's fine because, yeah, now give one picture. Ready? Picture.
Ready?
It's gone into the LV. Yeah, you're right, fluorescent. So we have prepared the valve. Come back to the coplanar view. Because we took that LIO for taking the valve. Now here we are fine. Okay. Center it properly. Mag it. That's good view. You have come to the good view, yeah? Okay, just come back little bit. A little bit forward, sir, forward, sir. Okay, that's fine. Okay, give one picture, please. Picture. Ready? Sini, sir. Okay, so the pigtail is in good position. Just show that, please. Show the cine we have taken. So we probably a little bit high, sir. Yeah. So we'll go down little bit. About there is fine, sir. Okay. This time we'll do it under rapid pacing. We'll not inflate. I will say rapid pacing, inject. Only few seconds. Okay. Yeah. Cine, sir. Cine. Pacing on. Inject, inject. Okay, down, pacing down, pacing down, pacing down. Don't worry about that. Pacing is important. So it's pretty. No, it's just show that. That is good, sir. So it will foreshorten up to the second dense band. Yeah. Maybe just one marker down, just little bit. Okay, that's okay. Okay, sir. Okay, now we are going to go now. That's okay, sir. Okay. Cine. Pacing on. Inject. Go up. Up, 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 up. Yeah, full. 3000. Okay. Pacing down, balloon down, pacing down. Yeah. Good. Okay. Store that. Remove the valve parallax. A little bit RA or something. Yeah, perfect. Perfect. Stop there. Fluorescer. Okay, ready for one injection. Yeah. Fluorescer. Inject. That's fine. So there's a little bit of leak. We can post dilate. Position wise, it looks good. It looks a good depth there. So the question. It's okay, ma'am. We have to post dilate. Just cine, sir, cine. Just plain cine. Okay, because LV said it's not opened up. So we'll post dilate. Just take the balloon back in, sir. Back in. Bit more. Stop. That's okay, it will come up. Don't worry. Anesthetist can manage that. Okay. Ready? Pacing on. Cine, sir. Go up, ma. No, yeah, perfect, sir. Pull on. Down. Pacing down. Fluorescer. I'll just come back and then we'll do a tap there. Okay, pacing on. Yeah, pacing on. Yeah. Go up. So that's a double tap. Okay, down. facing down. So the valve is expanded more on the aortic side than the LV. That is okay, sir. That's the way it is. Go to LIO. You can give some pressure support, please. And remove the parallax. Go a little bit cranial. Bit more, bit more, bit more, bit more. Stop. Here it looks well expanded. Okay, plain cine, sir. Plain cine. Okay. I'll just walk out the balloon back, sir, a little bit, and then we'll take a picture. The balloon is also on the way, and some of that AR is probably the wire induced. Yeah, so one sec. Fluoro, sir. I'll just pull the wire so it's center now. Yeah, we'll just take it. Fluoro, sir. Okay, ready for injection. Give 1 mag up. Yeah, that's fine. Okay, Cine. Inject. That's fine. There's nothing there. Now we can do the echo. That's a good position. Both coronaries flowing. Now there is nothing there. In this view, it looks well expanded. Depth is good. So we'll just take this out and put a pigtail. Walk it out. So we keep this ready for loading, sir. Okay, come, you do it, come. So, sir will fluoro, you walk it out. Yeah. So once it comes inside the loader, wait, don't put your hand, wait. Yeah, so you can take with the loader. Perfect. Give one pigtail, please. Come. So put the pigtail. Don't do the echo now. We'll put the pigtail and then do the echo, because if you have a stiff wire, it will cause AR and leaflet open. The pressure is okay. The pressure is absolutely fine. The wire is causing that ectopics. That's enough, man. That is enough. We will be taking only one more picture.
What is the rate now?
That's okay, but that will come. So just leave the pacing on. We'll sort it out. Leave the pacing on. Leave the pacing on. The own rhythm is coming through. Leave the pacing at 60 on demand. Take this out. Connect the pressure, sir. We can connect the pressure. Leave it on 50 on demand, because the own rate is around 55, 60. There's no gradient. Okay, that's fine. Okay, IA up. Show the echo, please. The STL is almost 75. So, and we saw in the iotogram there is no AR. Okay. It's bleeding us, sir. This.
Here.
Should let go, sir. Let go. Let go. Yeah. Okay. IA up and give some space for the echo. Oh, you're doing it. Sorry. Let's see the echo. Let's also see it. The position is, so that position is good, and yeah, no AR. Yeah. Yeah, continuous wave. Yes, yes. Yeah, freeze that. Take this one, yeah. Now, considering it's a type 1 bicuspid, but the advantage is there was no calcium in the raphe, so we could fully open it. Take this one, yeah. That's fine. Just take a trace. Aortic trace. Yeah. So it's 4/2, something like that. That's okay. Store that. Okay, now show me the heart. I want to see the pericardial effusion because any kind of balloon expandable calcified pericardial effusion is the most important thing. Yeah, there is no pericardial effusion. So pericardial effusion, regional wall, then aorta. So you come from the outer. So pericardial effusion first, regional wall motion, then the aorta. So no regionals, no pericardial effusion. Aortic valve looks fine. Yeah, that's perfect. Yeah, beautiful. No effusion. Yeah, nice. We are done. The rhythm is recovered, sir. Now it's sinus rhythm. Yeah. Leave the pacing at 50. That's okay. Or even reduce it to 45. Let the own rhythm work. What was the total heparin dose? Keep the wire. Keep the wire. Don't remove it. Keep the wire. 11,000. So we can give around 60 protamine. There is no coronary stents, no? No, we can give 60 protamine, please. Beautiful. Narrow complex, normal PR and... yes, sir. Yes, sir. We'll ready for the crossover. Come to PA and show the abdomen. Which one, ma? That is okay. Yours is a balloon expandable valve. If it's self-expandable, you will be worried about pressure. It will push it out. This will be fine. Is there any inotropes going? No. Yes, sir. Yes, sir. It's okay. It's coming down. 175. So take it out and give a JR4. So we have to back the sheath, sir. Without that, we cannot cross. Give that 14 French dilator. You put it in this wire, the 14 French dilator. Otherwise, the expandile part will bleed. Protamine is going, huh? Show this wire. Where is the wire? Yeah, it's above. You can lock it, sir. Lock it. Yeah. Now come back slowly. We'll see the radiopaque marker. Yeah. Below the bifurcation. Yeah, about there is fine. That's fine, sir. That's fine. Now do the crossover. Give the thermo wire, please. Take the catheter forward, sir. Yeah, about there is fine. Remove the wire, connect the pressure to that. So anything happens, we can put amblets through that and occlude it. Connect the pressure. Okay, good. Protamine gone, sir. Give some saline, please, to wet the sutures. Let's contrast. Saline. Okay. So you come this side. We'll take the two arms of the proglide, sir. Or you take the two arms of the proglide, the longer arms. Yeah, shorter, both longer arms. Don't mix it. Don't mix it. One second. So let it be there.
This one also I will put.
Yeah, put it so that.
Where is the other one?
Yeah. So both. So Keep the tension, sir.
Yeah.
I'm just coming out. You are ready for pressing? Yeah, ready with that 8 French sheath? 8 French sheath, 8 French sheath. Yeah, you can sedate the patient, please. Give the 8 French sheath, please. Put that, put that. So just keep it half in. It's nice and tight. So we can leave this, sir, and then take the knot pusher. Give the knot pusher, please. So one by one, we'll tighten the knot. So we'll separate this so that it doesn't get twisted. Okay.
Not for sure.
Yeah. Feels tight, sir? Yeah. Perfect. And then same thing we'll do with the other one. Okay. Okay. Put this together. This together. Okay, so it gets crisscrossed. It will not. The knot will not hold. Wait, wait, sir. Don't cut it.
Not cutting.
Okay.
No, I'm only pushing.
Yeah, that's okay. Just to put it, we need to tighten this as well. After that, we'll do that. The knot locking we'll do after that.
Okay.
Because the final, if you do two together, then it will lock the knot.
Separate.
Separate usually. The final part, oh, you are losing blood. Come this side. Don't let your hand go because the blood will be lost. Yeah. Okay, sir. Okay. So let's see the picture, and then if it's okay, then we'll remove the 8 French. So just put those together. We'll do that later, sir, because we have still got the 8 French sheath. Gentle pressure. Okay,
Yes.
come IA down.
You ready?
Okay, show the femoral head. Femoral head. Femoral head. Okay, when we say remove your hand, you remove your hand a little bit. Okay, okay. Remove your hand. Picture.
Yep.
Yeah, that looks okay. Just gentle pressure.
Is there anything? This side.
Another is
Nothing,
branch.
nothing.
There is nothing. It looks good. So we'll just do one by one. How much protomin given? 60 given, no? Now we need to tighten up. Just press it. I'll come back with the sheath and then tighten on the wire. Just coming out. Yeah, now tighten over the wires. Huh? So leave the white one. French or 6 French?
Today
No,
we
no.
have done
angiocell.
one
Because
TAVR
it's the
case.
7 French sheath, no?
This is, let me introduce
Okay.
the case. Is a 67-year-old gentleman without any comorbidities. He presented with exertional dyspnea and recently some episodes of giddiness. So echocardiogram showed almost 90 P gradient and 60 mean gradient. Severe AS. Then we did TAVR workup in view of there is no AR, purely significant severe calcific aortic stenosis, symptomatic status. So now I request our guest faculty, Dr. Anantaraman, to discuss about the CT TAVR protocol and strategies of the procedure.
Oh, thank you, sir. Firstly is the indication, does this patient need TAVI? And the answer is yes, because he's got symptomatic severe aortic stenosis, he's breathless, and also he had a syncopal episode. So that part is taken care. Now the second thing is it TAVI or is it a surgical aortic wall replacement? He's 67. There are some comorbidities. Both can be done, but at this point in time, for this age group, the risk with the TAVI is less than 1 to 2%, so it's acceptable. Now the third and most important thing is the lifetime management. So he's 67. If we are doing a TAVI now, then we should be prepared for another TAVI in 10 years' time. If we cannot do that, then I would have sent him for surgery. So surgery now and then a TAVI later. So because the anatomy is suitable for a TAVI now, and then another TAVI in 10 years time, then TAVI is okay. So lifetime management is taken care. Now coming to the finer details, it is a bicuspid type 1, right and left was fused. We'll show that in the next screen. The importance of CT assessment and then deciding between TAVI and SAVI. That's very crucial. There's a TAVI favorable and there's a TAVI unfavorable. So the CT anatomy is very important. So as far as the annulus goes, it's measured around sort of 430 to 460 area, which is around 23 to 24.5. So if we use the Merrill platform, you have the intermediate size, which means you don't need to sort of add volume or reduce volume. You can directly go with a 24.5. So that was the reason to use the Merrill valve here. The intermediate size means it can be appropriately sized. The LVOT was more or less the same. So that is the reason for using the 24.5. The coronary heights were adequate, more than 11 to 12 both sides. And the STJ height was good. The STJ height is an important factor when we use a balloon expandable valve. If you have a low STJ height and you are using a valve which is going to be 24.5, and if your STJ diameter is 23, then you should not use it because you will cause more trauma. Now we are increasingly understanding the STJ is important. The next important is the LVOT and LVOT calcium. Before going to that, all the other parameters, the sinus diameters, everything looks good. And show the next slide, please. Yeah, now this shows the important information. This is a right-left fused. It's a bicuspid. The fusion raphe is shown by the arrow there. But the important thing is the fused raphe does not have calcium. It's a non-calcified raphe. So this is what we call a TAVR favorable bicuspid. If this was completely calcified through and through, it is TAVR unfavorable. Then surgery is a better option. So this is a TAVR favorable anatomy, which will open up well. LVOT is more or less the same size. Show the next slide, please. Next slide. Yep. So there was a little bit of horizontal aorta. Show the next slide, please. Yeah, this one shows the horizontal aorta. It was more horizontal when we did the fluoroscopy. It is not 56. It was more than sort of 70 plus. And it's also tortuous as well, tortuous anatomy. The usual coplanar view, we will get it in aleocranial, but in this patient, we got it in areocaudal because of the tortuosity of the aorta. Next, please. The femorals are very good. That's another important aspect. If you are using a balloon expandable valve, you should have a femoral more than 6.5, ideally more than 7 if you are using the Merrill valve, but 6.5 is okay if there is no calcium. So both femorals are good and both femoral bifurcations are below the femoral head. Next, please. Next. So that's fine. So the anatomy wise, we have discussed that
Tell him not to stop there.
is 67. So the plan is to use a
Video
24.5 Merrill balloon expandable valve. The coronary heights are good. So if he has to have a TAV in future, then we have an option of putting a 23 or even a 26 self-expanding valve in future, or even another balloon expanding 23 inside this 24.5.
The video should be continued.
Yeah.
Continue. Yeah.
So if we have to use a TAV in future, then we still have the option of either using a short in short, that like a 23 and a 24.5, or a long in short in future. So the lifetime management is taken care of. Now coming back to the procedural details, left is for pigtail contralateral access and right is for the main access. Show the next, please. Keep going. Next. Keep going forward. Stop. So what was done was 7 French sheath on the left femoral artery and venous sheath that was for pacing wire. Right side was punctured and 2 proglides were put, one at 11 and one at 2 o'clock. Previously we used to put at 10 and 3. The wider the angle, the more stenosis and more cinching you get. So narrow angle is better. It creates a parallel thing. Next, please. Next. So this is the areocaudal aortogram. This shows the coplanar. It's the right-left fused and the non is kind of separate. Next, please. Next. So AL1 was used. It took about 5 minutes because of the nature of the valve as well as the sort of raphe. Next, please. So initially the turmo wire was attempted, but it was bouncing back. So a Teflon straight was used. once it crossed, as it is shown here, you cross in the orifice, but it should fall into the commissure. So the whole system is fallen into the commissure, hugging the non-coronary pigtail, which is what we want. Next, please. So once you cross, then you put a double length J wire and then exchange it for a pigtail. Next, please. Next. So once the pigtail is done, then this is Safari extra small, because the Safari extra small gives the advantage of moving the wire inside the LV safely, especially with the horizontal aorta. Next, please. So even though we were using a balloon expandable, because of its bicuspid, we opted to pre-dilate. The gradient was very high. The hemodynamic showed the mean gradient was more than 70. The echo gradient was more than 100. Next, please. So this is a 20/40 Z-med balloon under rapid pacing. Just go and show that balloon inflation. So it showed, because it's a non-calcified raphe, there was initial resistance which suddenly gave up. So the balloon fully expanded, which gave us the reassurance that the valve will fully expand. Next, please. Next. 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 Keep going. So the 24.5 was taken and it went smoothly to the LAO view. Then the valve was flexed. The retroflexion was used. With the retroflexion, valve was taken through the arch without contact, because there was a slight ascending aortic dilatation. So you don't want to make any contact with the dilated aorta. Once you are in, next, please. So if you can see the light and dark bands, so you better keep it around the second dense band at the bottom of pigtail. Next, please. Next. So you can see the dense bands nicely. So the second dense band, next, please, at the bottom of the pigtail. Next. Yeah. Next. Next. So my practice is usually we do a rapid pacing run and then take one aortogram before inflating. That shows us the stability. Next, please, show that. Yeah, this one shows that is a rapid pacing with that. Next, please. So this was a good position. Next. Yeah, this is the rapid pacing with injection. The stability was absolutely good. Next, please. Now next is the inflation. It's a very slow inflation. Go back and show. So rapid pacing, and then you will see the inflation is very slow. There is an injection as well to confirm. Yeah, and it's fully inflated. It's almost 1 mm depth. Next, please. Next. That showed there was some paravalvular leak on the left side where the raphe is. So the same volume, same balloon was taken, and an LV tap as well as an aortic tap is done. That's called the double tap. Show the next. So this is the LV tap. You see the expansion. I want you to concentrate on the left side below that calcium. The valve is expanding. And the next one, that's the aortic tap. Now the valve looks more sort of symmetrical. After this, there was no leak. Next, please. Next. Yeah, there was no paravalvular leak. Go back and show that aortogram. Absolutely fine. Not even a single orbis is going through. So that's good. So we are satisfied with the result, and there was no conduction abnormality, normal PR, normal QRS. Next, please. After this, the pigtail was put. Hemodynamics showed no gradient at all, good AR index, and echo showed the mean gradient was 2 to 3. And no paravalvular leak and no pericardial effusion. When you do the balloon expandable, make sure there is no pericardial effusion, no regionals, coronaries are good, and the femorals are closed. A half dose protamine is given, and the 2 proglides was used. Show the next picture, please. Last picture. Next one. So it shows as a slight singeing, but no stenosis as such. That's the advantage of narrowing down the angle. So this was done under sort of local anesthesia with conscious sedation, and the left side is closed with angiosyl as well. So the groin is completely now all sorted out, and pacing wire is removed. So the patient can be shifted to CCU and made mobilized maybe tomorrow morning and discharged tomorrow evening, because it's absolutely fine now.
Thank
So
you.
the
Thank
lifetime
you.
management is taken care.
Thank you, Dr. Anand, for honoring our invitation and helping us in conducting this case. And Tuesday, don't forget, we are going to have matter clip. Tuesday. Morning or afternoon you want?
Morning.
Morning. I'll keep at 8:39.
Yeah.
I'll see the flight schedule and I'll fix it up.
That's wonderful.
Good.
So normal.
Nice result.
Yeah. Thank you. Congratulations to all.
When is your flight?
I think it's 8 o'clock. It will be fine. So if I
Okay.
leave in another 5-10 minutes,
I think right time only.
yeah.
Modi